So welcome everybody to our Fireside Chat number 162. Today we have got Professor Pooja Amarapurkar. I hope I said the last name correctly, who is going to be our speaker. She has completed her training at the University of Miami and later on was the faculty at Emory University, where she developed the sickle cell kidney clinic at the Grady Sickle Cell Center and the e-consult service to improve access to care. Currently, she's a professor assistant professor in medicine at the University of Pittsburgh, Department of Medicine, Renal and Electrolyte Division. Dr. Amarapurkar leads the Onconephrology program at the University of Pittsburgh and collaborates with the Adult Sickle Cell Disease program at the University of Pittsburgh Medical Center. She's a nephrologist who loves to care for patients and help them along their journey. Her scholarly and research interests are in onconephrology and sickle cell-related kidney disease and improving access to care using e-consults. She is a clinical educator at heart who works on projects and research that is very practical and useful in our daily life. It is her passion to get trainees at all stages excited about nephrology and onconephrology and provide the best possible care to our patients. And she will be taking us through the topic, exploring nephrological implications of sickle cell disease, case-based insights. Prof, the floor is yours. Welcome.
Thank you so much for the kind introduction. And I'm truly humbled to share the stage with you and talk about this topic, which clearly, like I was mentioning earlier, is something that, all of you might see at such a great density. And as the population ages, I think knowing the impact on the kidney is very important. So I have no disclosures, and I want to walk through some introductions, some pathophysiology about sickle cell and how it affects the kidneys, some screening and workup. And in terms of management, we all know that there is some general management for the sickle cell disease per se, but then also I want to focus on how we as a nephrologist can impact patients with kidney impairment. And then we'll walk through challenges about kidney replacement therapy, transplant, and things like that. And I'll share with you some insights about our center and team as we end the chat. At any point, if you have questions, please feel free to ask them, and I will do my best to answer them. So I do not have to preach to the choir and tell you what sickle cell disease is. It's a genetic mutation and a chromosomal abnormality where we have an abnormal abnormal hemoglobin formation. And there are subtypes based on the inheritance, with some being homogeneous in a homozygous inheritance and some being heterozygous inheritance, which is the sickle cell trait. Not just are these inheritance subtypes a little different, but there are some clinical phenotypes. And one question you all might ask is, why do certain patients are predisposed to certain side effects of the sickle cell disease, or rather the manifestations of disease versus not? So this is an explanation to why certain people have, vaso-occlusive disease, some people have vasculopathy, hemolysis, some are lucky enough to have high fetal hemoglobins and tend to have lesser problems, and then some have the pain phenotype. So clinically, also, we see patients with different clinical presentations and predispositions to certain pathologies. Like, for example, some patients are more prone to ischemic strokes, pulmonary hypertension, and liver issues, whereas, nephropathy might be another set of population. So all of this together it's a genetic composition, predisposition, and certain factors, as we will learn along the way, that predispose to these patients having a certain type of kidney disease or liver disease and things like that. Again, I do not have to, cannot emphasize more how many more patients you see as compared to my clinical practice. And, really the burden of sickle cell lies in Africa, and even in India, for example, for that matter, we do see a good amount of sickle cell disease. With the Caribbean population and a lot of the African American population in America, we do have a lot of sickle cell patients as well. And there are pockets in the South and in the states close to the Caribbean region where we do see a good number of patients, and we have some great sickle cell centers around that area. So, the epidemiology is needless to say, but I think the point that I want to highlight over here is the prevalence of CKD is something that we cannot neglect. And, as the population ages, as the patient's longevity improves, we're going to see kidney disease in a good chunk, 40 to 50% of these patients. And especially as they age over 40 and they survive that, we're going to see more and more kidney disease. And I'll talk about it in just a minute, but along with sickle cell per se, there are going to be so many other factors that are going to promote the formation of kidney disease, or rather promote the chronicity of kidney disease, that we have to be mindful about this population and try to help them as best as possible. So one might think, where is the data coming from, or what exactly does burden of kidney disease mean in these patients? So as you can see this graph over here, there are several huge, large trials that looked at either pulmonary hypertension or some other modality or of treatment, say like hydroxyurea, or even the studies which were like multi-center and were looking at some other therapies like sildenafil and such. All of them put together came up with this really nice graph about the decline in GFR. And as you can see over here, the steep slope of decline in GFR with patients with sickle cell disease is much more steeper than the ones in patients without sickle cell disease. So as the population ages, there is tendency of the GFR to decrease. Some might have early progression to dialysis. There is obviously an increased mortality. And with kidney disease plus, say, for example, pulmonary hypertension or liver disease or something like that, we're talking about like a multi-system or a multi-organ issue, and that definitely increases the mortality in these patients. And unfortunately, rates of lung transplant or liver transplant or even kidney transplant remain low in these patients. So the point is the burden is real, and as the population ages, we're going to see more and more of these patients in our adult nephrology practice. So I want to start with some case scenarios to try and dive deeper into what is the pathophysiology, what are the clinical manifestations, and what can we do for these patients. So these are my three actual patients. So I'll start with a 32-year-old man, African American male with hemoglobin SS disease, is found to have an albuminuria. His albumin to creatinine ratio is about 574, and he is referred to nephrology for further management. So this is one type of presentation, and we'll talk about it in details in a minute. Then you have a 27-year-old who has recently started a new job as a mechanic, but comes to you because he's had frequent urination and he has to work long hours, and that's really bothering him. And then is your slightly older patient with sickle cell who's transfusion dependent, noted to have an elevated creatinine several years ago, and now has hyperkalemia, blood pressures in the 140s. So these are not uncommon patients, and these are real life situations that you might come across. So let's see what is different in each of them and how each of the pathologies are different. So what really happens in sickle cell in the kidney, right? So when a patient does have sickle cell disease, the medullary environment in the kidney is a perfect setup for low oxygen tension to begin with. And then in addition, when you have an anemic patient or you have a patient with sickling, that adds on to the low oxygen tension. It's hyperosmolar, which causes the tendency to sickling, and it's acidotic. So it's perfect for for the cycle to continue, where the cells will sickle, repeated hemolysis, veno-occlusive episodes, reperfusion injury, oxidative stress, and so forth. So unfortunately, the kidney is an ideal setup for the sickle cell cells to cause a sort of a vicious cycle of vaso-occlusion, endothelial damage, inflammation, and eventually lead to chronic kidney disease. So as you can see here, let's walk through the nephron and see what happens at each part of the nephron. So to start off with, in the glomerulus, the glomerulus is, the capillaries are small, tendency of endothelial damage, sickling, TMA is quite high there. So they are very susceptible to hypoxemia, vasoocclusion, oxidative stress. And this repeated cycle leads to hyperfiltration and eventually albuminuria. And then over time, the hyperfiltration is exhausted, and then you see a reduced in GFR. Some of the biomarkers they've tried to look at to pick up these early signs have been nephrin, endothelin 1, and so forth. Now, moving along the nephron, the proximal tubule. In the proximal tubule, what happens is with repeated hemolysis and sickling, the free hemoglobin can actually cause oxidative stress, tubular damage. As we all know, hemoglobin, like in situations like rhabdomyolysis and things like that, those proteins are toxic to the tubules. And just like that, the free hemoglobin can be a problem to the proximal tubule. So the types of RTA, production of ammonia is a problem. Phosphorus metabolism can become a problem in the proximal tubule. Moving further down in the vasa recta and in the distal part of the nephron, that nephron is also prone to similar damage: ischemic injury, microinfarction, papillary necrosis, and all these things time and again, when they happen repeatedly, give rise to your hematuria, impaired urinary concentration ability, reduced potassium excretion, and things like that. So as you can see, the goal is, unfortunately, the main driver of all of this is this vicious cycle of sickling, oxidative stress, vasoocclusion, and things. And as this happens over time, these repeated injuries can cause various manifestations in the kidney. Just to summarize all the kidney manifestations of sickle cell disease, it can start off with glomerular hyperfiltration. Albuminuria eventually happens. We'll go on to talking a little more in detail about the actual glomerular pathology, what you can see on a kidney biopsy. Proximal tubular dysfunction with phosphate. These patients also have increased creatinine secretion, and we'll talk about that in just a second. Tubular ion deposition, decreased ability to concentrate, just like our patient who is, going to the bathroom all the time. Impaired ability to handle the potassium, acidosis, hematuria, medullary carcinoma, and papillary necrosis. So really, every component of the kidney has been affected by the sickle cell process. Now, circling back to our patients. So we have our 32-year-old with hemoglobin SS and found to have albuminuria. So he probably has albuminuria from hyperfiltration and glomerular disease over time. And this is probably the first time he had access to care or got a checkup, because otherwise he was okay. And we'll talk about what it means to screen for these patients. What are some of the standards that are laid down to screen and monitor these patients for albuminuria as we go along. Now, in the 27-year-old who's having a frequent urination, that's the impaired ability to concentrate the urine. And this is almost seen near universally. And then sometimes as they get older, the GFR decreases, that goes away, or sometimes they get transfusion dependent, and that sometimes helps as well. And the 47-year-old is something that I see quite frequently in my practice, who has improved longevity because of antibiotics, improved transfusion, handling of ferritin load, and then they develop CKD. And as a consequence of CKD, they'll end up having RTAs, hyperkalemia, elevated blood pressures, and things like that. All right, so just switching gears now to go into further granular details of what the pathophysiology is and talking a little more about the biopsy lesions. So I have an 18-year-old with hemoglobin SS and is found to have a new onset of albuminuria. And his albumin to creatinine ratio is about 1500 or 1.5 grams. He remains transfusion dependent once every 3 months. He's been taking hydroxyurea, and blood pressures have been ranging from 110 to 120, and he's referred to nephrology. So the question is, what are the possible lesions that you can see if you were to biopsy this patient? So we see a host of lesions in the biopsy if we were to biopsy any of these patients. And we'll talk about when and what would prompt you to perform a biopsy as well. And I would love to hear from you guys, what are your practices also? So the FSGS is one of the common lesions. Membranoproliferative pattern is also common. Thrombotic microangiopathy from repeated sickling, endothelial damage, that's commonly seen. Eventually, hypertrophic glomeruli, distended capillaries, that also is just naturally because of the hyperfiltration, hypoxemia, these changes make total sense. And then hemosiderin or even iron deposition in the tubules is almost universal in repeated hemolysis patients. However, nephrotic syndrome is not very, very common in these patients. The proteinuria is generally subnephrotic, but if there is a component of nephrotic syndrome, you want to rule out simple things like parvovirus infection, and it doesn't necessarily come along with a great renal progression. So something to think about when you're evaluating a patient with proteinuria and sickle cell. So these are the various pathology images. So starting from here, these are the iron depositions, as you can see the blue dots with the Prussian blue stain. This is the hemosiderin deposition in the tubules, again with Prussian blue iron stain. This is the sickle cell nephropathy. As you can see, these sickle cells, this is an EM image in the glomerular capillary loops. And here you can see these red blood cells over here, which is sort of a TMA or a thrombotic microangiopathy pattern with, and lastly, you can see the glomerular capillaries occlusions with these red blood cells. And these are some of the common findings if you were to biopsy the patients. All right, so let's switch gears and see what else can we, how better can we understand what goes on in the kidneys. So now we have a 32-year-old with hemoglobin SS, about 1200 ACR, referred to nephrology. His creatinine is 0.4, blood pressure is 120/75. He's taking hydroxyurea, gets pain crisis occasionally, and he comes to you and he's like, doc, what does my kidney health look like? So now we have somebody who's relatively young, who is on hydrea. His blood pressure is slightly on the higher side. His GFR is pretty good. However, he does have proteinuria. So this is again a typical patient that you might see, and this is in particular a dear situation because you want to help this 32-year-old not progress to CKD as best as you can. So let's start with hyperfiltration. So this man clearly has hyperfiltration because his creatinine is 0.04 and he does have a good GFR. So hyperfiltration is one of the first things to happen. And as you can see, it can increase with age, but eventually the hyperfiltration does start decreasing. This occurs because the anemia can cause an increase in cardiac output, medullary hypoxia, prostaglandins, and sometimes creatinine is not the best value because sometimes with hyperfiltration, the creatinine can actually be hyperfiltered, more secretion, the creatinine can be very low. So in a patient with like this, even if his creatinine goes from 0.4 to say 0.8, that would be a significant AKI, even in setting of the creatinine being in quote unquote the normal value for us. So something to keep in mind. Then what is a good test? So back in the day, 24-hour urine collections were something that we did often, but now they're testing various CKD equations, and the CKD epi equation has the lowest bias and sort of a good equation to use for GFR in these patients. Cystatin C has been talked about, but it's still in the works, and between the CKD epi 2009 equation and the cystatin, this equation tends to do a little better than not. But the point here is hyperfiltration occurs, and unfortunately, as age goes by, you might not have the benefit of hyperfiltration, and we need to keep a close eye on this. Now, so what about albuminuria? Is there a correlation with age, or how does this happen? So this is actually a poster we presented at the ASON a couple of years back, and these are our own patients from my sickle cell clinic. And as you can see, there is a slope downwards with the GFR and age. So hyperfiltration eventually goes down and the GFR decreases. But in terms of the albuminuria, the plot is pretty scattered. So it's not necessary that the albuminuria either increases or decreases. And like we mentioned earlier, some patients might be more prone to albuminuria versus the others. And we'll talk about some more genetic factors to come in the next couple of minutes. And clearly, our patient that we're talking about, he already has 1200 ACR, and so his trajectory is not the best. So in terms of renal dysfunction, various studies have looked at the percentage of renal dysfunction, and the prevalence is quite high, as you can see in this particular study, where 27 to 28% of adults landed up having kidney dysfunction in some form or the other. As you can see, the hyperfiltration eventually goes down as age advances, urinary concentration ability more in children, and then sort of improves with age. Also, progression to ESRD, ESKD is associated with poor survival. So kidney problems are real in these patients. Now, if you notice, our patient was 32 and his blood pressure was 120 over 80. So just keep that in mind, and we're going to talk about it very soon. So as you can see, the rates of renal function decline, unfortunately, are higher in patients with sickle cell disease with CKD as compared to patients who do not have sickle cell disease. So that is an added compounding factor to progression of CKD in these patients. Now, like I was saying, let's talk a little about hypertension, okay? And so this is another case. So we have a 50-year-old, again, has some albuminuria. Creatinine is 1.6, and the GFR is about 57. But his blood pressure is 130 over 85. He takes hydroxyurea and is referred to a nephrologist. So what's going on here? What is abnormal, or what do we think, right? What should we consider in this patient? So first thing is he does have already has evidence of CKD. He has evidence of albuminuria, and his blood pressure is on the higher side. So traditionally, we think of patients with sickle cell having lower blood pressures. But now, as the population increases, as they're having more albuminuria and CKD, it is something that is, being brought up and seen more commonly these days, that they do have evidence of hypertension, and it's actually a problem now that we need to worry about. Traditionally, we think of, okay, if they have high albuminuria, we are limited with the use of ACEs and ARBs because of lower blood pressures. But now, as the population ages, this is also something that we need to consider. So from my own patient population over here, as we can see, that prior history of hypertension was there in about 52% of the patients, and most of them did have a GFR less than 60, their ACR was higher, and they were not just on one medication. Some of them needed more than one medication for the treatment of high blood pressure. Again, hypertension and GFR correlation, it may not project really well, but the point is that from our cohort here, we did see that lower GFRs had tendency of higher blood pressures as compared to higher GFRs. So the patients who had higher GFRs are in the blue, and the patients who had lower GFRs are here. And as you can see, the patients who had lower GFRs had a higher history of hypertension as compared to the ones with better GFRs. And the similar thing, we saw a similar trend with albuminuria. So the higher the albuminuria, the risk of hypertension was more. And I came across this really nice study from Ghana, which looked at they even looked at relative hypertension, normal blood pressures, relative hypertension, and hypertension. And they noted that even relative hypertension, say for example 120 over 80, which technically is normal, but for a patient with sickle cell, this could be relatively high, is also getting more prevalent, and this is becoming a mainstream issue. This is actually a very nice paper, and they did try to look into other comorbidities associated with sickle cell in this population, and they had a great number of patients as well. So why do some people have worse kidney outcomes, whereas some people don't, right? So it's not just the sickle cell. So sickle cell is one piece of the puzzle. Unfortunately, these patients can have other genetic influences that can be helpful or that can make their kidney disease worse. So, for example, kidney disease is more prevalent in those with hemoglobin SS, with some some thalassemia variants, APOL1 genes, MHY, and some other bone morphogenic protein 1B. Whereas co-inheritance with alpha thalassemia actually is a little protective towards albuminuria. And then the polymorphism in the B cell lymphoma leukemia gene also leads to higher fetal hemoglobins and leads to decrease in hemolysis and then is beneficial. So there is nature has its own ways of promoting disease versus offering some sort of an immunity, and these are certain other genetic factors. And then you add in things like use of NSAIDs, diet, other comorbidities, other infections like HIV or hepatitis B, C, and then things like that. And then that can complicate the matter as well for the patients. All right, so we have a next case here. You're consulted to see a 35-year-old with sickle cell disease who's admitted due to acute chest syndrome and is noted to have hemolysis. Laboratory data suggests of hemolysis and an acute kidney injury. T-bili is elevated, clearly hemolyzing. She also has some nausea, poor intake, blood pressures on the lower side. So what's going on here? I find that in terms of conversations about sickle cell, we often talk about the chronic kidney disease aspect of it, but there is a huge burden of acute kidney injury as well. And luckily, the chronic kidney disease piece is a bigger piece of the puzzle, but this is a non-negligible entity that we need to think about, because when these patients do get sick and are seen in the hospital, they do have enough reasons to have acute kidney injury. So let's see what is some of the data, and then I'm not aware of that many registries or databases that actually look into this topic. But if any of you would want to collaborate on looking at acute kidney injury and sickle cell, I would be very happy to work on this together. So depending on what study you look at, it could complicate 2 to 8% of hospitalizations with vaso-occlusive crisis or acute chest syndrome. Volume depletion is a big cause for it. We still don't know whether every time somebody gets anemic, do they have an AKI, or is this is there no correlation with that? That still remains unclear. And then incidence of AKI during vaso-occlusive crisis associated with acute chest syndrome or pulmonary hypertension can also raise this other question of the role of like right ventricular dysfunction, venous congestion, and things. And oftentimes, bile cast nephropathy is something that we cannot ignore, because as I shared with you, the patient has a bilirubin of 32, and that's another component of AKI in these patients. So if you look at the pathophysiology of AKI, you can see several pathways that lead to AKI. Venous congestions from repeated sickling, hemolysis, hyperbilirubinemia, free hemoglobin, tubular injury, nephrotoxic meds, volume depletion, impaired renal perfusion causing ATN, hepatorenal syndrome or hepatorenal physiology when the liver is involved as well. So basically, so many pathways lead to AKI and sickle cell disease. So it's not just volume depletion, and we should broaden our horizon when we think about what causes an AKI in patients with sickle cell so we can treat them appropriately. And I'm going to talk about, I just said nephrotoxic medications like NSAIDs, but there are a few chelating agents that we use, and I'm going to talk about them in just a second, which are also an important cause for AKI and something to think about. So now we know the problem. So how can we screen for it? How can we look for it? And what can we do about it? So in terms of screening, everyone, all patients with SCD should start screening from the age of 10 years. In my practice, what happens is I already get patients who have already been screened, sometimes established with a cause of AKI or sorry, cause of CKD, and that's when I receive it. I'm not sure how many of you deal with the pediatric population, but screening them annually at an early age is definitely recommended. A positive dipstick should lead to quantification, repeated checks to make sure it's not getting worse, and then when appropriate, referral to nephrology is also indicated. This is a very nice schematic talking about how we should go about screening for albuminuria. Repeat every 3 months. If it's stable, you can space it out, and then the use of RAS agents if it's progressing, that's something common. And I think our hematology colleagues are pretty good at doing this. And then I think when things get out of control beyond this, that's when we often get to see, at least in the adult world, that's when we get referrals. However, this might look a little different for the pediatric population because sometimes if the albuminuria is worsening or progressing, that's when people can consider a biopsy, or if their hematuria is worsening or there is a rapid decline in kidney function, some patients might need a biopsy to rule out other causes. I did have 2 or 3 cases where the patients had almost nephrotic range proteinuria when they were a child, and they did land up getting a biopsy only to show a MPGN kind of pattern and a very sickle cell nephropathy related kidney disease. And then unfortunately those 2 patients did not do well, and they landed up on dialysis in their mid to late 20s. That's when I took care of them. What other workup can you do in the spirit of completeness and to make sure that we have given the best possible care to our patients? Apart from quantification of the albumin to creatinine ratio, protein to creatinine ratio, making sure for hematuria, urine microscopy, cytology, CT urograms for persistent hematuria to rule out any papillary necrosis or any cancer, that is important. As the population ages, ruling out things like myeloma and other conditions like hepatitis, HIV, autoimmune diseases. Unfortunately, we had a few patients who had lupus plus sickle cell, and it was a complex situation to handle those patients. And then and a consideration of biopsy always becomes very tricky, especially in the adult world when you inherit them already having kidney issues. But if you do need to biopsy, it's worsening albuminuria, sudden nephrotic syndrome, or rapid decline in kidney function, and so forth. I don't put it up here, but the prevalence of diabetes and checking for diabetes also becomes very tricky in these patients because your A1C is not a good enough indicator. So in that setting, keeping that in the back of your mind and just evaluating them holistically and making sure they're not on NSAIDs, which is also a very hard situation. That's some of the things that you can do in terms of workup for these patients. So now coming to sort of the last few minutes in view of time, and I want to be respectful of everyone's time. So how do we manage this patient? So as a nephrologist, what can you do or what should you know about that is out there that is new, right? So many moons ago, the only thing that we had was hydroxyurea. But as you can see from this paper in Blood Advances, now the horizon for treatment of sickle cell per se has really expanded. We've gone from hydroxyurea to having a buddy called Veloxetor, which is also used to increase fetal hemoglobin, to anti-selectin inhibitors, to anti-inflammatory agents, to use of L-glutamine and things like that. So the horizon is expanding for the treatment of these patients, which is great. And thus understanding how these treatments would implement kidney function is also important. So what are sickle cell targeted therapies that we have now, and what are some of the trials that are going on? So traditionally, hydroxyurea from the Hustle study has been shown to decrease hyperfiltration and proteinuria. Up until recent times, that was pretty much all we had, and then ACE inhibitors and ARBs to help with the CKD. The voxelotor also increases fetal hemoglobin, and there is an ongoing clinical trial looking at the effect of that CKD progression and how patients would do with an increase in hemoglobin. This medication sometimes is not well tolerated. Patients have a lot of GI side effects. So, it's in my practice, the Hydrea has been a little better tolerated than this medication. The crisanilizumab, it's an anti-selectin agent, and there was a trial called the Steadfast trial that was looking at renal side effects. So the hope was that it works on the capillary endothelium, prevents, sort of having repeated hemolysis and things like that, and to see on how that worked on the kidney function outcomes. Now, oftentimes the other question that comes to our mind is, and I briefly alluded to it, is how bad or how major is the role of the anemia or the acute anemia in the presence or in making the kidney function worse? And I believe this question remains unanswered. We do use ESAs in these patients in conjunction with our hematology colleagues. They might need higher doses, or they often need higher doses. There is a good amount of ESA resistance. And remember, in kidney disease, you do not want to have such high hemoglobin targets like 10 to 11. You want to have lower hemoglobin targets in these patients, because the higher hemoglobins may actually predispose them to a sickling problem. So my colleague, Dr. Julia Zhu, she's been very excited about this study where they're trying to look at hydroxyurea and EPO. What's the right dose? What's the right hemoglobin target and such? And they piloted this study in, I want to say, either in Nairobi or one other center too, and that's one of their main projects between last year and now. Then the next question is, but why don't we do a stem cell transplant in these patients, treat the cause, and then hopefully get, not have to worry about the chronic problems. So a lot of these patients have a problem because they are transfusion dependent. So in terms of getting antigens matching stem cell transplants for these patients can be a problem. Sibling matching can be a problem because the sibling might have a problem as well. And then the conditioning regimen used for a stem cell transplant is pretty extensive, and that itself can predispose these patients to infection, to a host of other problems, which make stem cell transplant a not so very feasible option. And we have, less than desirable rates for this. Luckily, there are modern medicine is trying to make progress. So CRISPR therapy and another gene therapy based trial are just about to start. And at our center, the 2 patients are waiting to have a gene modification therapy to see if that would help their sickle cell. And again, these therapies are expensive, they're not mainstay, and access to care just becomes difficult, right? So what else can we do for these patients? So some of the other interventions that have been looked at is chronic transfusion, to see if there is reversible in renal injury, especially the concentrating ability. We have another trial going on called SCD Care, where they're looking at exchange transfusions and looking at incidence of stroke and other complications to see if that would help. But again, it's an expensive endeavor. It's an exchange transfusion. It's not an easy process. So, we'll see what the data shows. I do want to spend the last few minutes on iron chelation, and I'll come back to that in a second. But avoiding NSAIDs sometimes can be very difficult in these patients. And ACEs and ARBs are, the bread and butter to treat these patients. Low blood pressures and high potassiums may limit that, but as you see, these patients sometimes can have hypertension. Use of diuretics for hyperkalemia makes it a little tricky in these patients because you do not want to dehydrate them or volume deplete them in any way. And I'll talk about chelation in now. So chelation therapy, as you know, when these patients undergo repeated hemolysis, they have iron deposition, and iron deposition can cause a host of its own problems, right? So there are 3 commercially available chelators, at least for us over here. Desferal is the nephrotoxic one. It binds iron and primarily excreted through the urine. So we don't use it in CKD patients, but you can use it in hemodialysis and peritoneal dialysis patients. And hopefully that can help bring down the burden of the ferritin levels and help promote like anemia care and, just generally, hopefully improve the lifestyle for these patients. The deferoxir is an interesting medication. So I actually had a patient who came in, and I was not the attending physician that time. Somebody else had taken care of the patient, came in with severe diarrhea, acute kidney injury, creatinine was about 6, needed dialysis. Somehow this medication got stopped because nobody knew what that was. They stopped the medication. She got off dialysis, diarrhea improved, went home, started taking it again, came back again with bad diarrhea, bad AKI, needing dialysis. So even though this medication is excreted through the feces, there is reported kidney toxicity with Fanconi's and acute kidney injury or acute kidney failure with this medication. So this does need dose reduction with decrease in GFR, and we need to be very careful as the use of this medication becomes more widespread. And the last one, the feriprox, that's metabolized in the urine, so try to avoid it in CKD patients. And since these are rather new, we still don't have enough data about these medications. So when we did, there's actually a sickle cell conference that occurs every year, and we presented our case with AKI in that conference, and it was very interesting how some of the physicians I met there actually came up to me and told me that, we've not had that many post-marketing events, and we would actually like to keep a track of these events to see. And then when you look up, you see a lot of reports of Fanconi's and AKI, but but there is evolving literature in this area. Now, as a nephrologist, right, that was all supportive care and in partnership with hematology. So now what is our role? Like, what is our true role, right? So when these patients do progress rapidly, land up on hemodialysis or peritoneal dialysis, we do have some problems with hemodialysis, access clotting, lower hemoglobins, lower blood pressures become a big problem. Potentially, peritoneal dialysis might be a better option. It's gentler. I try and encourage my patients to be on it because they're younger, they have more autonomy to do stuff on their own. Kidney transplantation becomes a very mucky territory, unfortunately. In America, still we have issues like racial bias, access to care. Importantly, trying to get a living donor for these patients becomes a problem because their sibling could have sickle cell too. They could have a risk factor like APOL1 genes, higher risk of infections, splenectomy is done, blood group incompatibility, other comorbidities like liver disease, pulmonary hypertension. Immunosuppression is not easy in these patients. So, using steroids or even things like tacrolimus and other immunosuppression might not be easy because of the comorbidities and then the thrombotic complications. And overall, this is just a very, very complex set of population where a lot remains to be determined and a lot remains to be practiced and tried to help support this community. But with better management and early recognition, I'm really hoping that we get these patients ready or optimized for even at least a consideration of transplantation. This is a very good study, came out just about a year or two ago, and it looked like they looked at patients with who were candidates for kidney transplant who had sickle cell and who did not have sickle cell. On one hand, they saw that, if they are optimized, also remember, if they are ready for a kidney transplant, that means there is a very, very subgroup, specialized group of patients who have really, beat all the odds to be there. And in that setting, they didn't see that many adverse outcomes, but the truth still remains that to get these patients optimized enough to even be listed for a transplant remains a big challenge. So that remains hopefully we can change that someday with the big kidney transplant and things like that. So, in summary, this is a very complex population. They have a high risk of complication. With increased longevity, we are going to see more complications like hypertension, but we want these patients to survive longer. So, it's very reassuring that we can actually see these patients in our adult population clinic. And we need to have it's easier said than done to have a stronger approach to transplant referral, but having a good supportive care to keep these patients alive and functional, I think is an unmet need, and also the hope that newer therapies can actually help these patients live longer. So with that, I am very lucky to work with all my colleagues at this University of Pittsburgh Sickle Cell Center. We have an adult and children's program, and then we're one of those lucky centers where we've had a bunch of patients transplanted with not just kidney transplant but liver, lung, bone marrow, and we have a few trials to offer for them, and we're and two of our patients are being considered for this gene therapy. So hopefully the next time we talk, I might have something exciting to tell you about how they do. With that, I want to stop sharing and thank you for your time.
Thank you very much, Prof, for this enlightening talk and a very comprehensive review on sickle cell disease and sickle cell nephropathy. So I'm glad that we had this talk, and I'm sure our audience must have benefited quite a bit from this, despite us living in sickle cell endemic area. I feel that this is something that is not very frequently taught and not very frequently accessed, because by the time the patients come in, they may not actually know that they have the sickle cell disease. That's the first thing. Or the second thing is that they've already missed the boat and they're already having end-stage kidney disease, and then we have to, treat them. We do have, especially in Tanzania, we do have a very active hematology center, and the National Hospital actually has a sickle cell clinic that deals with patients with sickle cell. Though I must say that I'm ignorant of the fact that if they actually go ahead and screen patients for renal complications, that is something that I probably need to just find out for myself, and I know somebody that I can get to answer that question. If not, then probably I would suggest that they should do that before we miss the boat. So that is one take-home point for me, that by the age of 10 they should be screened for proteinuria. So maybe if I can, before we take questions from the audience, maybe if I can ask you a couple of questions.
Absolutely.
So I'm glad that you mentioned gene therapy as one of your last points, because that was my question that I wanted to ask you. We know that stem cell transplant is it's fairly aggressive, and the pre-treatment that is required before transplant is done is fairly aggressive. So what is the role of gene therapy as part of the curative treatment for these patients if it is successful? I know it's very expensive and it's not accessible even in the developed countries, but it is something that probably something to look out for.
Yeah, absolutely. And I think so. Gene therapy in general, I think the way modern day medicine is moving, being able to alter the genetic makeup and to take away the risk factor for a disease, like philosophically and poetically, it's the most beautiful thought ever, right? Now, in terms of and some of the questions that do arise, since I'm a cautious optimist, is that with in terms of the gene therapy, we don't yet know what is the optimal timing? Is it when the baby is a year old, 2 years old, 3 years old, intrauterine? We don't know that. So that becomes one unanswered topic or unanswered question in terms of, where gene therapy would lead us. Then comes, okay, so if we do the gene therapy, how would that impact the chronic burden of disease that occurs with sickle cell? And then and then the unknown remains. What are the consequences of gene therapy, right? Like, what if the vector goes rogue? What if the gene mutates on its own or like these remain to be determined and learned from. And I think right now, there was 2 or 3 days ago, there was a New York Times article about, I think, two patients being prepared for this potential gene therapy. So, only time will tell how it would impact. But I think the big question also that arises is, like, at what point do we do it? Because in my mind, if somebody already has liver disease, pulmonary hypertension, and kidney disease, putting that person through the whole process may not necessarily yield us the same outcomes as if you do it in somebody who is not yet a victim of the chronic complications of the disease. But I I I'm eager to know as well, from just as you are.
Right. Thank you, Prof. That's great. The next question that I wanted to ask you was, so you briefly touched on renal replacement therapy for these patients. So say you have a patient that comes through who has got sickle cell disease and he's got sickle cell nephropathy with end-stage kidney disease. Now, this patient is one of those vaso-occlusive phenotypes that has got painful crises, vaso-occlusive phenotype with painful crisis.
Yeah.
Now, the challenge comes through is that the blood viscosity is directly proportional to the vaso-occlusive crisis. Now you end up with a patient who has got no renal function or residual renal function. Patient is on dialysis, and you need to ultrafiltrate them just to make sure that they don't get into overload. And so how do you manage that particular situation, in the sense that you need to find a balance between not dehydrating them so that you don't precipitate the crisis, but only keeping them too much overloaded, otherwise they get other complications from the fluid.
Yeah, so this is an ongoing challenge. And if you see such a patient in the outpatient setting, it becomes an even bigger challenge, because there's only so much that you can do. So oftentimes when we encounter things like that, these patients are already in the hospital, and then doing very small sessions of of ultrafiltration, maybe every so often, or being very cautious with how much fluid they're gaining, or how much fluid you are actually giving, and trying to balance that out becomes a huge challenge. And the other problem also becomes, is because they're so vasodilated, the blood pressure is low, so there is only so much ultrafiltration you could do at any given point in time. And then this is a very, very tricky situation. And I think the best way we've handled this so far is, we are very gentle with doing ultrafiltration. Maybe do, like, keep an eye out on their pulmonary situation. And also, the other problem is, it's very hard to differentiate between pulmonary edema causing all the lung symptoms versus vaso-occlusive crisis versus something else. So we typically resort to very, very gentle ultrafiltrations, just to make sure that we're not overdoing it, and we're not increasing the viscosity. And we we do enable the hematology teams. We do tell them that if you do need to give fluids, we'll be on board, don't worry, we can co-manage. In certain situations, if we need to use continuous renal replacement therapy, we've done that. I distinctly remember this one case where her hemoglobin was 5, and she was, ESRD patient, hemoglobin of 5, dialysis dependent, and and her potassium kept remaining high. And we really came to a critical point where our hands were so tied. I will never forget this patient, but she made it. What we did do was, we kept giving her some blood. Like there was only so much blood we could give her because she was highly sensitized. So between fluids, blood, and a little bit of continuous renal replacement therapy running at very low rates, we somehow saw her through a week of hospitalization. But I believe that was truly a miracle.
Thank you. Thank you, Prof. So it is a challenging scenario, and I feel like we just need to find the right balance and probably individualize treatment for each and every patient that comes through. And then maybe just my last question before I go to the audience. You did mention something about the parvovirus, and if you have got rapid onset or high proteinuria. And the reason why I'm just trying to kind of fit that in, is it because they are at a higher risk of developing parvovirus infection because of the bone marrow issue?
Yes.
Is that
Yes.
the case?
Yes, they're at a higher risk of parvovirus infections as opposed to normal individuals. And parvovirus can also cause collapsing FSGS there is a known association. So those two things together can give rise to a rapid decline or rather nephrotic range proteinuria and then kidney problems as well.
Thank you, Prof. So there is a question about the role of SGLT2 inhibitors for the albuminuria that these patients have. What was your comment on that?
So, this is a popular question, especially since these medications have been so rampantly used now. The risk of volume depletion is not insignificant with the role of SGLT2s. I believe somebody was trying to work on a study to look into this, but it has not been a mainstream. We tend to shy away from using SGLT2s because if you mechanistically, if you look at it, these patients will tend to have reasons to have proximal tubular damage from the iron depositions or free hemoglobin and things like that, and then it's just a very slippery slope, and I'm not sure anybody is brave enough yet to go ahead and use these medications. So we've tried to limit the use of, I have been very, very cautious about using these and actually not use them.
Right. So perhaps alternatives before you decide, unless you're very pressed.
Yeah.
Right. Thank you
yeah,
so much.
exactly.
Thank you so much, Prof.
Yeah.
We have got a comment from Professor Kilonzo. He's a nephrologist from Moshi, at the foothills of Kilimanjaro, and he's actually put in a journal article, a 2019 study that I'm sure if I remember correctly, he was a co-author. It was a study that was done in northwestern Tanzania, and there was a high frequency of renal dysfunction among sickle cell disease in their clinic. It is a good center to collaborate. The center's name is KCMC, and they do have a low prevalence of sickle cell disease in high altitudes, but it is something that he would be grateful to have a talk and collaborate. Professor Padilla Kilonzo.
Absolutely. Yeah, and that's a very interesting thought, right? In high altitudes, is there a particular reason why we would have a lower prevalence of sickle cell disease? Because at higher altitude, it's like natural selection, right? Just like you have the ApoL1 gene to prevent the sleeping sickness. It's quite interesting to see if that would be a reason why at high altitudes they, as a way of natural selection, don't have that high risk of sickle cell.
I'm not sure if the other panelists have got any questions. There is nothing yet from the participants. Prof. Bima, please go ahead.
Thank you, Pooja, you said that proteinuria usually starts around about 10 years of age. Am I right?
So actually, no, proteinuria does not necessarily start at 10 years of age, but the National Blood and Lung Institute recommend screening for these patients at 10 years of age. We sometimes see kids who are, not me, but some of the patients that I've inherited, their proteinuria has started probably early on as well. There is really no specific age limit to when proteinuria could start.
My comment is because more that I must say I haven't been troubled by the hematologist very much with sickle cell disease, because unless there's a crisis with AKI or something.
Yeah.
I think in the last 2 years I've had one patient where we needed to do CVHD because of the fact that the patient had a AKI, a bit of hypotension, and but that patient also was septic. You know what I mean?
Right.
So I I don't know whether people are screening these patients sufficiently, or because if you pick up proteinuria early, I mean, like diabetics, etc., I think they should be treated early
Yes.
because it's preventative. You understand? I mean,
Yeah.
so I don't know why the recommendation was from 10 years. If you say it's
That
unset earlier.
Yeah, that's a very good question, and I wish I had a good answer for why it's considered 10 years. And I mean, if it were for up to me, based on the diagnosis, based on what so one explanation could be that maybe there is some amount of also because the fetal hemoglobin in or in kids is much higher than as compared to adults, right? So if the fetal hemoglobin is higher, they tend to have lesser complications, and that's one of the arguments against stem cell transplant, because you could say that okay, if they have sickle cell, if they're diagnosed, let's just go ahead and do the transplant right away before they get to, all the complications of it. But there is a protective period because of the high fetal hemoglobin. And then as the fetal hemoglobin decreases, the percentage decreases, the complications increase. So I'm guessing that's where they try to find a sweet spot and say 10. But actually, I will bring up this discussion with my hematology, like my pediatric hematology colleagues, to see if they have seen any benefit in screening earlier. Because by 20, if they're like, I have a bunch of patients in their mid 20s, and they've had kidney disease for at least 10 years. And then at that point, I'm just like, what, like your point is very well taken. Why not just screen them earlier, like in diabetes?
No, I'm just saying because ACE inhibitors and somebody brought up SGLT2 inhibitors. Those things are protective. You know what I mean? Renal
Yes,
protective. So
yes,
you can prevent these patients from going into end-stage kidney
yeah,
disease
absolutely.
by more time. See?
Absolutely, absolutely.
Mm.
I think the only explanation I can think of is the protective role of fetal hemoglobin till a certain age, and then having the complications after. But um, I'll definitely bring up this point in our next discussions about at what age they feel comfortable screening. Um, Also, the other bias is and this is an extrapolation from my experience over here, is that if in the young age, or if in the childhood, a child gets by not having any sickling events or pain crisis or things like that, they tend to be they might be considered protected in some way or the other. But having said that, the people who do land up having a lot more complications may be screened. There might be a screening bias as well, where somebody who's sick and goes to the hospital frequently maybe um, has these screenings done earlier. But I think that's a great point to bring up and see what practices are
I know.
across.
I just want to follow up on that. That was proteinuria. But one of the things that you did mention was these patients have hyperfiltration. Am I right? Now, hyperfiltration itself is a problem and it
Yes,
should be managed appropriately because that can lead to adaptive FSGS.
yes,
Not necessarily nephrotic syndrome, but it can lead
but
to adaptive FSGS with nephrotic, even severe protein or moderate to severe proteinuria, right?
yes.
So it's another reason why I think, screening should be earlier, not just to treat massive proteinuria, but even if there's mild proteinuria or else there's hyperfiltration, this patient should be managed, appropriately with an ACE or something.
Absolutely. And I think the hyperfiltration problem in these patients is like, it's not a blessing. It is,
Mm.
it actually needs to be taken up seriously, like you say. But I think the challenges with reducing hyperfiltration in these patients is putting them on ACEs and ARBs. And if they are in that phase where the patient is not hypertensive, putting them on ACEs and ARBs might be a very challenging situation. But I completely agree with you that hyperfiltration should be stopped, and it's a problem. which eventually gives rise to CKD and, other issues. But yeah, these are very, very valid points you bring up. And I think that's why we need to have more of these discussions so we as nephrologists can come up with something.
No, thank you very much.
Yeah.
Thanks, Aman.
Thank you, Prof. Nima. Thank you, Prof. So I'm going to end this meeting now. Thank you very much, Prof, for your insightful presentation. And it was fairly enlightening, and discussion was also quite productive. And I believe that all our participants have enjoyed this talk. The talk will be available on YouTube in a few days' time for those who have missed it and for those who want to revisit it. And Prof, we would like to welcome you back again at your free time to come in and discuss another topic of your choice to our forum. We're very glad and very privileged to have you. Thank you so much.
Thank you very much.